Right, hello again. So today on our prescription form we are going to be looking at the Kirby Skive. So devised originally by Dr. Kevin Kirby in America. Stuart, give us a little bit of a chat about
the Kirby Skive.
Kirby Skive, yeah.
Okay, so essentially it's a little inclination based mostly on the inside of the foot for controlling rear foot pronation. So if you've got an idea of where your subtalar joint goes in the back of the foot, this is a little takeaway. We take it away from the cast.
So you can see a flattened area there, can't you?
That's right, which will then add material to your device. Okay, a little flattened piece there.
Okay, and on our form we've got a little box there with millimetres so that the practitioner can specify, the clinician can specify how many mils they want that Kirby Skive to be. So I know the most common we do is 4 mil, but it doesn't have to be 4 mil, does it? So
be technically anything you want depending on the size of the foot.
What would you recommend the highest? Because of course the higher you go the more aggressive it becomes.
That's
and
correct.
The patient might not tolerate it.
So again, typically depending on the size of the foot, a size 4 foot's very different to a size 20. Okay, but you can use your clinical judgment there. We tend to see 4, 6, 8, sometimes 10 mil, but the 10 mils tend to be the highest that we'll generally go to.
Okay. Now the other thing that's important with the Kirby Skive is that we think about the lateral border of the device as well, isn't it? Or having a good heel counter on the shoe. That's
correct. So everything that you do on a medial side, you've got to think about what you're doing to control it on the lateral. Okay, or the posterior or the anterior. Okay, we're in a triplanar world. If we increase more force on the inside of the foot, if there's nothing on the outside, the foot will technically slide off the device. Again, with your footwear and your device combination.
Yeah, so again, that's something to think about with the prescription form. You don't want to be cutting narrow or doing something like a reduced bulk and then having a Kirby Skive, because one thing kind of cancels the other out, or doesn't make it as effective, I guess, does it?
That's right.
So really a Kirby Skive we choose if we want more control, if our rear foot posting isn't quite enough, medially deviated subtalar joint axis, that kind of thing. Now, Stuart, is it helpful if clinicians mark on their casts where the axis is?
Most definitely.
Is it? Okay.
Yeah, most definitely. The main reason being is we need a reference point to know what angle the foot is at, to then create a 3/4 distance from the lateral side, 2/3 distance from the lateral side, 1/3 distance from the medial, and that's where the centre line of the Kirby angle will start.
Okay. Now we haven't got enough time today to talk about medially deviated subtalar joint axes and all of that. If you're not sure about it, if you go on the LBG Medical website, click on Education and then Videos, there's a 45-minute video on there that talks about medially deviated subtalar joint axis, how to find it, how to assess for it, prescription variables, do's and don'ts, and pretty much everything you need to know. So, but for now, that's the Kirby Skive.
Welcome to it.
Thank you.
Cheers.